Welcome to today's webinar on behalf of the Illinois Academy of Family Physicians. Today's webinar is the Brain Trust, and our presenter is Dr. Shah, Professor, Department of Family and Preventive Medicine, and the Rush Alzheimer's Disease Center at Rush University Medical Center. A few housekeeping tips for us. All attendees are in listen-only mode. If you have a question, please enter it into the chat feature. We will read these questions aloud at the end of the presentation, and please note that all questions and answers will be part of the recording. This is our faculty disclosure. The Illinois Academy of Family Physicians adheres to the conflict of interest policy of the ACCME and the AMA. Dr. Raj reports being the site principal investigator or sub-investigator for Alzheimer's disease clinical trials for which his institution, Rush University Medical Center, is compensated by Amylyx Pharmaceuticals, Althea Pharma, Edgewater, Next, Eli Lilly and Company, and Genentech. Peer review content prior to this activity has ensured evidence-based content using best available, highest strength of evidence. This presentation has been found to be without bias, and there is no conflict of interest for Dr. Shah to present this information. All staff and planning committee members involved, Kate Valentine, myself, Desma Rozovics, and Dr. Avanish Mantha, the CME reviewer, has disclosed no relevant financial relationship or interest. Here's our accreditation statement. The Illinois Academy of Family Physicians is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. Both the live webinar and the enduring material online offers AMA PRA Category 1 credit. These are available for one AMA PRA Category 1 credit, as well as one AAFP prescribed credit. And this is how you claim your CME credit. For our webinar attendees, there'll be a link to the post-test eval, and a credit claim will be in the chat box at the end of the presentation. Additionally, this link will be emailed to you after the presentation. If you are participating online as enduring, a link to the post-test evaluation and credit claim can be found in the video description. Please click on the More link to see the full link and the video description. There you will find the link for the credit claim. The CME activity will meet the state Illinois requirements for continuing medical education required for physician license renewal for recognizing dementia. And if you're interested in more information, please check out thebraintrustproject.com. There you will find additional CME online enduring material, our series of CME podcast episodes, as well as an online resource tool. Support for the Brain Trust is as follows. The Brain Trust is a project that is sponsored and administered by the Illinois Academy of Family Physicians. Funding for the creation of the Brain Trust project was made possible by a grant from the Illinois Department of Public Health. Funding for this webinar is made possible by Eli Lilly and Company. And now on to our presentation. It is my honor to
Okay, great. I don't know if Desma froze a little bit on the screen, but I appreciate being here. And I hope that I can send the request to share my screen for my slides, Kate. So I'm sending the request.
There you go.
All right, and I will pick the slideshow. Share.
There we go.
Okay. Great. Hopefully everybody can see the screen. So thank you again to the IAFP and the Brain Trust for enabling me to come back and to talk through the early detection and treatment of Alzheimer's disease and dementia. So I'm really looking forward to sharing in the next about 45 minutes some of the information that we think is really important for family physicians to learn about in delivering care to people with dementia. And then I hope I can have time where we can answer questions and update on some of the new advances happening in the field. So make sure, there we go. So our learning objectives for today are to work through and understanding the barriers that are associated with the early diagnosis and treatment of Alzheimer's disease and dementia. I want to just share some processes to make it easier and for our family physician colleagues to feel more confident in how they can approach making a diagnosis and sort of the constraints in our practice environments right now. And then I'll highlight some of the aspects of treatment and research options for individuals with cognitive concerns and their families. And really what we'll be doing is what's the state right now of our knowledge and what we're understanding about the conditions, just level set with some ideas and concepts about dementia that so that we start at the same place. Talk through where are some of those barriers we're seeing in people getting an evaluation and a diagnosis early in the process of dementia. Think through some practical solutions and pragmatic solutions that would be amenable to use and implementation and after this presentation and within the next 3 or 6 months in your practices. And then how do we keep working on learning together and growing and developing sort of this learning community around how do we improve the lives of people living with and at risk for dementia. Let's talk about where we're at right now and what's sort of happening around dementia and our understanding. So these are some, every year, the Alzheimer's Association, working with epidemiologists and other special individuals knowing about things about caregiving for dementia and primary care for dementia, puts out a annual facts and figures report. And based on that estimates, and actually it's some of the work that's been done based on populations in Chicago to make these national estimates. In 2024, it was estimated that about 6.9 million Americans have Alzheimer's disease or related dementia. And these disorders of Alzheimer's disease and dementia are the third most costly disease in the United States after heart disease and cancer. We are anticipating that, we kind of project or know that in 2024, there are people that are not in the pie graph that represent people developing Alzheimer's disease or related dementia before age 65, and there are about 300,000 people estimated in the United States. But we see that this pie chart is kind of following what's happening with the advancing of our aging population. Where the group that's going to be the highest in number right now in having a prevalence of dementia is within the 75 to 84 group, but not far behind is the 85 plus group. And then the projections, without us kind of continuing to work on finding disease modifiable and prevention mechanisms to lower the incidence of dementia onset and then slowing its progression once it's diagnosed, is we're going to move from about 6.9 to, by 2060, an estimated 13.8 million people in the United States. And as the population ages, it's going to have a bigger percentage of people in that 85 plus group, where other geriatric conditions come into play, such as frailty and multiple morbidities. Now, one of the features from a few years ago with a special piece in Alzheimer's disease facts and figures was that when they interviewed primary care physicians, about 55% said there's not enough dementia care specialists in their communities to meet the patient demands. And that's why it's so important that we keep working as in the primary care space with family physicians and to recognize we're going to be a key player in helping to older individuals that are experiencing concern about their cognition to be able to get diagnosed with dementia if that's what their symptoms are pointing to. Now, if we bring it down from the national level to the state of Illinois, They do provide an annual update, and as of 2020, Illinois was in the top 10 states in the country with the number of individuals experiencing dementia at about 250,600, and it's about 12% of all individuals over age 65 in our state, and we have about a population of that of 12 million in our state and about 2 million people that are over age 65. And it does take time and effort. It's not only that person experiencing the dementia, but it's the entire network that supports them. And even if you estimate a one-on-one kind of caregiver or primary caregiver situation, and where we know that's not always the case, sometimes there's up to 4 or 5 informal caregivers that are sharing responsibilities. There's a significant amount of unpaid care that we depend on in the state. But those care mechanisms without the right support really impact the caregivers and their own health and their mood. And we have to keep working on recognizing that it's multiple people that are impacted. And as family physicians looking at the entire family dynamics and community dynamics, these are important things for us to be a part of and to make a difference. We understand that there are multiple ER visits for individuals and hospital rates that could be avoidable for people with dementia, and those have large burdens not only on the individuals experiencing the dementia, their caregivers, but also our health system as a whole and sort of the financing of it. Now, I was happy to find that earlier this year, that the state of Illinois published results that it collects as part of a CDC project, Centers for Disease Control. They looked at sort of the survey they did by phone to random digit dial. And every 1 or 2 years, they add a component asking people about over the age of 45, if they're called, to estimate how many people are experiencing confusion and memory loss. They were able to sample and combine the data from 2015 to 2019, and they found over 23,000 adults over the age of 45 who answered that survey. And based on the survey technique, they can move that to the entire state and make state estimates. They estimated about almost 500,000 people have reported to somebody who just called them on a phone for doing a survey, is estimated to have subjective cognitive decline. So a sense that their thinking and memory loss and sense of confusion is there. Now, this is starting earlier at age 45, but still points to a significant number of individuals experiencing this. And in that little bar graph on the bottom, I show like the breakdown in 65 plus, about 10% of the respondents that were over age 65 highlight that they're having troubles in subjective cognitive decline. We see the distribution by the state, and it's not surprising that the levels are sometimes twofold in parts of the state that are representing some of our more rural areas than what might necessarily be in the urban centers of Illinois, including the Chicagoland region. And if we look at the other map by county, we see there's sort of a distribution. And some of the ones that are just white, they just didn't have enough people sampled to give a good estimate. It doesn't mean that people there magically don't develop Alzheimer's disease or have cognitive problems. There just were not enough people to interview. But we see that as far as men or women experiencing, it's still about 9% for both of them, and a relatively equal around subjective cognitive decline, but significantly more individuals that were non-Hispanic, African Americans, and Hispanic were expressing these concerns of subjective cognitive decline. And it tells us we have to reach out to these really important cohorts in our community, including rural-based, African American, Latino, in order to better understand what is happening around confusion, which could be associated and be a symptom of a problem, including something like a dementia. All right, so with that in mind, about the magnitude of the issue and the number of people that are experiencing this at a national and a state level, I wanted to turn our attention a little bit to what do we mean when we are talking about what's normal cognition, what is mild cognitive impairment, what is dementia. And so we know that in general, cognition is very heterogeneous and with a lot of variability of what is normal when people are over the age of 65. But there are certain patterns where the cognitive changes don't fit in the normal ranges, and people are noticing these things and they're causing some issues about their discomfort in handling social situations and eventually developing lack of ability to do certain activities and tasks. And dementia is just one end of that spectrum. So in many ways, we go from sort of, I'm doing okay with my cognition and I'm testing fine and what we'll call normal, to this concept we just said, which was subjective cognitive decline, which could fit into eventually, if we did some more testing and saw that they were not having troubles with their function, into mild cognitive impairment. And then when people have cognitive difficulties that we can measure, and they're affecting their day-to-day life activities, that is the tip of the iceberg and what we consider dementia. Now, what is sort of normal? It's hard to study this because we have trouble studying people over in following them individually from birth to death over 90 years, 80 on average. The United States is about 80 years. So what we do is we look at a group of people that are in their 20 and give them the same cognitive test, and then some in their 30s, and then some in their 40s, and then some in their 80s, and every decade. And then we look at sort of the patterns that go on between the groups. And in general, there's things that we hold in our capabilities or even do steady on or get maybe a little bit better over time. And those are things such as reading and vocabulary, just because of exposure issues. And then long-term factual memory. So you'll hear this story like families will end up giving, which is something to the effect like, yeah, mom can't remember what she had for breakfast yesterday, but she can recall the dress she wore to her prom when she was 16. And that's just because of where the brain is holding that information, or the systems and networks in that crystallized memory function that are tied with emotional content tend to be remembered better over time than more recent and smaller things. We know in the middle what changes are things like attention span, as vision changes, as hearing changes. It becomes difficult for people to concentrate for longer. And then the thing that changes the most is usually speed, the time it takes to bring information back. The information's there, but it takes longer. It takes longer to perform certain tasks. And we're still trying to understand what is happening at a brain level, at a neuron level, that can understand why those things are happening over time. When we get into mild cognitive impairment, we get somebody, it doesn't always have to be the individual, it might be a caregiver, expressing the person as having more difficulties with a cognitive function. The main one we look at was memory, but it could be anything. It could be, difficulties with using appliances, which could represent like executive function. It could be difficulties with wayfinding that are new. And that could be your visuospatial abilities. It could be finding the right words, which could express changes in language. And that this is something that we can measure. Like, they tell us they're having problems with this area. And then we do some simple pen and paper tests in the office, and we can understand and compare them with other psychometric tests that show that they're having troubles in these areas. We look at other areas of their cognition, and they're mostly in the right range, and they're functioning well in those spaces. And we're not seeing that they're having troubles with stopping some of the day-to-day activities because of these issues. They're still social, they're still doing their hobbies, they're engaging in employment if they're continuing to work, or they're doing things around the house like they used to do. And we just don't have enough to make the diagnosis of dementia. That's fitting into this middle category of mild cognitive impairment. And then when we think about dementia, it's really this idea of chronic cognitive loss, that the person is having symptoms for a significant amount of time. Rule of thumb, there's no direct number in this, but it's lasting for over 6 months. It's cognition, so it's your thinking, and there's some change happening in it. And it's usually in the classic definition, you need an impairment in more than one area of cognition. So it could be something like short-term memory or episodic memory, along with visual spatial skills, and that we can't explain these changes in the memory and function during the course of another condition, such as it's not because the person has worsening diabetes and that's affecting their cognition, or it's not because they've had depression that's coming on and their thinking is slower. And we can't, so it can't be accounted by another disorder. And then it also cannot, it's not acute. It's not a change in cognition that's happened quickly and that we would call delirium. All right, so what are the things that can cause this chronic cognitive loss? Well, there are many, and there's over 100 types. The most common is that more than one change in the brain is happening, which is called mixed dementia. And the most common combination is a mixture of Alzheimer's disease and vascular dementia to make that mixed dementia present. But as an individual level, Alzheimer's changes of happening in the brain with what we call amyloid, which is this buildup of a version of that protein into plaques, and a change within the neurons or the in the brain in the transport mechanism that we call the buildup of tau or phosphorylated tau. Those two things are the main ways we think that Alzheimer's disease is present in the brain. And that accounts for about that those presence of those changes in the brain is in about 70% of people that have any form of dementia. Vascular dementia is associated with usually infarcts or signs of small strokes or bleeds in the brain. Lewy body dementia is associated with the buildup of alpha-synuclein, which is associated with Parkinson's disease in areas of the brain that affect cognition. And frontal temporal dementia tends to be tied in with changes in the tau proteins. And these are the most common, like neurodegenerative dementias we think of, and they have different patterns. But, at Rush, we've been part of some studies where we've been following people that have been healthy and they donate their brain at time of death after we evaluate them every year. And, even there in some of our studies, we see people develop cognitive decline, develop dementia. And we can't explain it by all the things we measure in their brain, like this AD pathology, this Lewy body, this vascular disease, these tau changes. And that's what kind of we have to remember, that there's still a lot we don't understand about what the driving factors are and the combinations that bring along dementia. But Alzheimer's disease tends to be a key player. All right, so with those things in mind, let's talk a little bit about where are some of these barriers and what's happening right now in how people can get early diagnosis of dementia. Well, there's barriers at multiple levels, and I think we've all recognized this and seen this in our experiences. There's definite barriers for individuals, persons, and their families. We're trying to get better at this with normalizing the stories that cognitive loss is not always a part of normal aging and can't just be expected with an aging process. But we have to be able to recognize that if something's changing in the cognitive function, that they do need an evaluation. And for many parts, that's getting through the fact that changes are just part of normal aging and they do need an evaluation. And then we have to do that by reducing some of the stigma that's associated with people having cognitive difficulties. People still think they brought it on themselves. They feel like they're going to be isolated and othered because they have these changes happening in their brain and people won't engage with them anymore. And that's why they fear the diagnosis and sometimes don't seek help. There are some people that, don't recognize that the process is happening, but that's not everybody. And sometimes that recognition may not come out in a statement, I'm having problems with my thinking, but it may come out in different ways with function and with mood. So, even paying attention to somebody who's older has been doing well, and now all of a sudden gets depressed or more anxious, we need to kind of look further if it's just the primary depression or there might be something else happening with their cognitive abilities. We still have a lot of problems, throughout the state and making sure there's access to services where people can talk with their primary physician, a family physician, about their symptoms, and then how do they go through, the process of diagnosis and treatment and feeling like they can afford it. Providers that are in this space, especially in primary care, in family physicians, face their own barriers. Sometimes they are frustrated that there's a feeling like even if I diagnose this, I can't do much about it. But I think that's been changing with us talking more about the condition, and that there's always things we can do based on our skills and our abilities to walk the journey with people going through a condition and helping to reduce the suffering associated with it. And the way I try to frame it is like, we don't have a cure for diabetes, but we still do a lot to help people with diabetes to manage their condition. And our society values that, and we are valued for doing the right activities there. And the same comes with how do we help people with conditions that are neurodegenerative, like Alzheimer's disease and dementia. It's hard to recognize what's going on and to put all the pieces together. And we'll talk through that in the next section about how we can get better at that. And then there are practice constraints just in the way appointments are scheduled. It's requiring a little bit more time. Sometimes we have to just think creatively about spacing some of the evaluations out or using some of the other opportunities like annual wellness visits to help us out. And then there's other difficulties after, like with community services and providers, and that's the coordination of sort of a dementia-friendly community with other providers that we can connect with as family physicians sit between that nexus between health systems and community systems to be able to support that holistic care of somebody that has been diagnosed with dementia over time. And what do these barriers end up being? I thought this was a nice summary of, talking with individuals that were patients and care partners and primary care providers. That was done a few years ago in 2020 and published in 2023. But just showing like the pathway isn't always so straightforward and has significant delays based on these interviews. And one of the key delays is the time it takes for somebody and their family to recognize there's a problem with cognition and to feel comfortable coming into an office and to talk with their family physician about their symptoms. That can take somewhere on the average of about 15 months, sometimes up to 3 years or more. And how do we make our practices more dementia friendly, that people feel like they can talk to us and feel safe, they can talk to us about these issues as they arise. And then in the process of going from the initial discussion to the diagnosis to treatment, sometimes that can be in the range of about 5 to 6 months. And it's again, like, how do we work on helping through people in that journey of the diagnostic process, trying to reduce some of the times for them to feel supported, to not help to prevent drop connections and how we go and approach those diagnostic features over time. I think I'll come back to this, but one of the more interesting kind of points of this article was how people view each other in the process. Where about 74% of the primary care physicians took on that 4C of coordination of care and felt that that was part of their role. And that's something they could deliver and have confidence and expertise in, but about 37% of the patients and partners viewing it as such. So we just have a gap in a little bit of expectations and understanding skills that we can hopefully reduce by continuing to do presentations and to revisit that and to maybe be very clear to people when they come in for an evaluation is, yes, I might need some help in certain aspects, to be able to, get to a diagnosis. But in the end, I am an expert like any family physician in the 4Cs. And one of that is how do we help to coordinate your care over time and to coordinate this diagnostic process. And then I think that educates our patient and our care partners to improve over time. All right, so what I'm thinking with those barriers, we have these rooms to reframe and to redesign and to think through them and look for those opportunities for us to be successful. And what I'd like to say is that, we do have skills around the 4 Cs. We are the first point of contact for care in most situations, and people bring up these issues to us first. It may take them a while, but eventually they'll connect into those spaces. We do think about the comprehensiveness of the diagnosis and the follow-up. We do great jobs around coordination, and we look at the continuity of the person overall. And we realize, based on, multiple surveys that primary care physicians are making the diagnoses in the current situations, because access to geriatricians and neurologists and geropsychiatrists are just limited. And that limits vary depending on what areas of the country and even the state you're in. And there was a very interesting report by Rand that looked at sort of how long it would take to handle the number of people we estimate that would have cognitive problems to get to a diagnosis. And in some parts of the country, their estimate was that to get to a diagnosis would take 100 months, over 8 years. And that the only thing in their models that changed that dynamic to shorten that pathway was connections and care with primary care physicians. So we play an important role in this space, and we have skills to do this and are doing it. And how might we build on those strengths to help to make an earlier diagnosis? And what I'd like to share is this 2023 article that came out where they did interviews with primary care physicians in California mainly, and they did these qualitative interviews about how people felt the primary care core values fit with dementia care. And it came through with the 4 Cs and coordination and contact, this holistic view of the person and how they fit in their dynamics of their family and their communities and these long continuity of relationships. And then we focus on things about health promotion, whatever is happening. And they didn't get to talk as much in their interviews about the prevention aspect, but it really points to these 4 Cs being very important. What I found was really interesting in some of the interviews and articles is the primary care physicians recognize their importance as the first point of contact. And what was hardest for them to think through making an early diagnosis was to feel confident about how to handle what would happen next after the diagnosis, and to feel confident that they had the skills in following people and coordinating their care to support them throughout the journey as things went on. And I think there's definite things we have in our toolkits that can help at that stage, and they will continue to get better over time. And then what is this way of building confidence? Well, there are actually surveys developed around sort of general practitioner attitudes and confidence in dementia care. And I will say there's things like we have to really ask ourselves internally and then work through by, having more presentations as a society, as the Illinois Academy of Family Physicians, through things like the Brain Trust about how do we reduce like question number 10 and people feeling this, like I feel frustrated because I do not know how to effectively treat people with dementia. So how can we help to reduce that? How can we reduce, I feel, and make it so that more people as the family physician feels confident in their ability to talk about legal issues associated with the diagnosis. And I'm confident in my ability to make the diagnosis. I'm confident to provide the appropriate care for the person. I'm confident to provide advice about managing care. And we can work through those pieces. And that's what the Brain Trust as a program and the podcast was trying to really express. And so I do recommend people, if they have a chance, to listen to some of those podcasts of your peers as they talk through how they're approaching the diagnosis from their own context. So let's talk a little bit about some of the pragmatic solutions. So we're facing this world where somebody's coming in at the end of an appointment where we have 15 minutes and we've got a waiting room that's booked, and they've got multiple conditions happening. And right before you're about to walk out the door, they say, and doc, I'm having troubles with my memory. Like that, and what to do in that situation, right? So the first thing to probably realize is it takes a little while to unpack like what may be going on and to get to a decision. And you need time. So something you can say at that moment is, well, I really appreciate you bringing it up because I know it sometimes takes people a long time to come to me, sometimes almost 2 years before they bring it up. So thank you for letting me know. We do need some time, and we should carve out some time next time in my schedule so we can talk through what is happening and to get to a better diagnosis, and we'll be able to make that over a couple of sessions if we need to. But I'll be here in the journey. My role is to help being your point of contact and for the continuity and for the comprehensiveness and coordination of this process. And we'll walk through the journey with you, whatever we find. So some messaging and some framing around that can really help in kind of setting the right tone and rapport to work through these things and to give yourself a little bit more time and space to be able to work through that diagnosis. All right, and how do I think about this? Well, there's a lot of engagement right now and excitement and thinking about how artificial intelligence will help us all in these spaces. And I don't doubt over time that we will get better at using these tools and making better sense of them. But in the end, they are tools, and they are tools for our own brain. And I always remember this as a medical student, just as an aside, by a cardiologist, where we were practicing listening to the hearts and thinking about like murmurs. And he said, if you hear a murmur and the echo report doesn't say that, who are you going to believe? And in the end, it's like, how do we train our human intelligence to realize the machine may not always pick up everything, even though it gets better? But we have to use our tools as humans that we are innately have and that we train as being a physician over time and practice and building confidence to handle how do we get to an early diagnosis. So one thing is just being open with our eyes and our ears to signals that might be coming through. And the classic one I provide here is pay attention to what your front desk team is saying about somebody coming in for a visit, because sometimes they pick up the problem of cognition before anybody else does, because the person is calling multiple times to reschedule their appointment, or they're calling multiple times to put in refills of a medication which was already filled and they were informed, or they come into the office because they thought this was the day they were supposed to come for a visit. Like all of those things are your eyes and ears in a team approach to help you to get to, recognizing, maybe I need to talk to them about cognition. And then the other thing I think we forget is we sometimes see other family members, especially the caregiver. And in many ways, the caregiver is that canary in the coal mine. If the caregiver is starting to get more depressed or anxious, if they're also having more troubles with their abilities to manage their own health conditions, maybe it's a good opportunity to talk with them about, what else might be going on in their caregiver responsibilities, and if they're noticing some changes, and that there could be a way to help them and the person who might be experiencing cognitive difficulties to get supported. And then use some of the points that are built in that we have available to us, like the annual wellness visit that our systems, if we're in a health system, are encouraging us to do, Medicare is encouraging us to do. How can we use that as a point to like step back, you get a little bit more time to do those cognitive questions that, the public health department's doing over the phone with people and asking about confusion and difficulties with memory. And people are saying yes. And then there's a follow-up that we can start and think our way through. Because there is no guideline right now for screening everybody, because we don't have the greatest tools for asymptomatic. And but there is, room for case finding. And if people start telling you they're having cognitive difficulties, that is where you start the case finding process and make the diagnosis one way or the other. So we have to inquire and listen. I'm going to share a little bit of an algorithm I've tried to teach people and use over in my experience over time to just help me through the process a little bit more efficiently. As a geriatrician, I have to remind people to also focus on function, because sometimes if somebody is losing a function, like all of a sudden they've given up on that hobby they really like, or they're having problems like handling the microwave, those are always signals that something is going on with that older adult and that I need to explore it further. Sometimes it's cognition, sometimes it's medications and side effects. It can be a lot of things, but at least I can start the process if I ask about function. And then I always tell people to remember about horses and zebras, right? Like we're most likely going to find horses in this scenario of a common condition. The sixth leading cause of death in people over age 65 is dementia. And we just have to be able to recognize that that could be present and then keep our eyes and ears open for something different in the story that we might need a little bit more help. And the zebra could be there. All right. So this is kind of the general like 3-step process I think about as I like to share with people. It's how to handle sort of an evaluation when you bring them in the second time and you have the 15 minutes. Remember, most of this is still about like a good history and listening to people, and sometimes not only the person, but a family member. But I ask myself these 3 questions to triage people. Do I think this person in front of me, my patient, has a chronic cognition problem? If no, I think it's only short term and it's started and I can kind of pinpoint a time that it happens and it's less than 6 months. Maybe I think it's acute and I have to look for delirium and go down that pathway. Or if I don't find there's anything going on with their cognition, maybe they're in that normal early stages of subjective difficulties, and I just might need to leave the door open to follow them over time and not make them feel like it was a waste of time for them to bring up that issue with me. And then we go to the yes, if there is a chronic cognition problem, and we have to think through, like, does this individual have a dementia? Is my second question. And dementia meaning they're having 2 or more areas being affected with their thinking, it's affecting their function. If I get areas that are affected with thinking, but function is intact, that's MCI. And this time I did the slides after 2 years ago. I actually put the ICD-10 code for MCI because documentation is important so that you have that as a resource over time. Okay, but now if I think, yeah, I think there's more here, there's some functional loss, I think it's dementia, then my first question, because it's so common in the pathway, is does the story fit with Alzheimer's disease? And if yes, goes to an Alzheimer's disease diagnosis. If no, I have to think about one of the codes for what other dementia type might be going on. And really the key here is to work through those parameters, usually in your history taking, and you'll have a working diagnosis by the time you're done with your history taking. And then you're going to use your physical exam and laboratory and imaging studies to then help you along the way. And here are some of the things to think about, maybe as far as some questions I put on. But really, it's about the history, trying to find that timeline to make sure it's acute versus chronic. And a common thing is people will remember the point where they recognize there was a problem that happened. Like it all started when mom got lost going to the Walgreens, and instead of going down the street 2 blocks, she ended up an hour away in a couple of cities down, and we had to go find her. And that's the date they remember when it happened. But then you push a little bit and you ask, and you said, oh yeah, she was. Then they come back and yeah, for the last 3 years, she's been a little bit more forgetful, and this is what's happening. So it moves it from an acute to a more chronic state of these problems. You want to ask about these memory history of present illness and some review of systems about their memory. And you want to rule out those things that were part of the diagnosis of dementia, like if depression is present, and then treat the depression if that's present, and see again with the cognition later on. Look at that function. Again, function is very important in giving signals and saying that it's past MCI to dementia, and then a medication review to look at what else is happening with people over time. And these are some of the functional changes that happen in the course of the disease over about 20, sometimes up to 20 years. On average, in the United States, it's somewhere about 4 years after diagnosis, but we're still a little bit late in the diagnostic period where it's pretty obvious. Many mentals are still at that stage, like as a benchmark, somewhere about 18 or 19 out of 30. And we, first potentials of seeing that there's cognitive problems can happen at like 25 or 26, depending on education and other experiences. But it takes a while, right, before people get to diagnosis. And when we tend to make it, we make it when it's really obvious. And then you're looking at sort of the instrumental activities, and I just tend to ask these straight out, about Miss Jones. I ask everybody about, how they're doing with their day-to-day routines. Are you having any troubles in getting to the local grocery store? Do you drive still? Does somebody else have to drive for you? Have you gotten lost? Medications, how has it been to keep up with your medications? Do you have a system in place? Finances, are you having any difficulties in paying your bills? Grocery shopping, cooking, house cleaning, telephone use. And then the basic activities of daily living include things like getting out of bed in the morning, transferring, walking to the bathroom, brushing their teeth, toileting in the morning, feeding, bathing over time. And then these are the SIGI caps for depression. You can pick whatever mnemonic you like. People tend to pick the first two questions and the PHQ-2 anyway in their practices. That can help you to understand that. And the physical exam is a lot about sort of where the vitals are and some simple memory test, mini mental state exam, MOCA, mini cog, multiple things that can be used to help in a short form to help people out. And then neurologic exam, you're looking for things like Parkinsonian signs or stroke. And your labs, you don't have to order it all the time, but if there's something in the chart recently in the last 3 months and they've been stable medically 6 months, you want to just see that you've looked at their blood counts and their chemistries and thyroid and B12. Sexual activity changes with older adults. So if you're in an endemic area, you have to also keep in mind about looking for things like syphilis with RPR. And then imaging has been, mainly in the United States, has been CT or MRI. MRI tends to be favored, but here you're really looking for those large strokes or masses that you can't pick up on the exam, especially in the frontal lobe. And then you're trying to piece the story together with all that information. If it's kind of a slow progressive loss, starting with short-term memory, it tends to be the pattern of Alzheimer's disease. If you're looking at more stepwise decline, somebody has a vascular stroke or a TIA, they drop in their abilities, and then they essentially plateau or improve with rehabilitation, then have another event drop. The classic stepwise pattern for vascular is given. Not all vascular looks like that, but that's a common pattern. Lewy body dementia, you might get hallucinations and falls and not necessarily tremors, but stiffness and Parkinsonism. And you have to be a bit careful with them about if you hear that with any antipsychotics, because they could get neuromalignant syndrome happening. And then frontal temporal, they usually have difficulties less with memory, but more with language or executive functions. And I'm not going to go through, I'll go through one example just to give us a sense of how this can work, but I have other examples that, people can look at a little bit later. But take this one as a case example. An otherwise healthy 72-year-old woman is evaluated in your clinic because she's forgetting for the last 4 years. Over the last year, she's been struggling to recall names of friends and relatives. She recently drove down a one-way street the wrong direction and is no longer able to manage her own finances. She denies feeling of depression. Her mother had similar symptoms in her 70s and died in a nursing home at age 79. The patient's physical exam is notable only for the mini mental state exam of 23 out of 30, and she had difficulty recalling all 3 words on delay after 5 minutes, apple, table, penny. And routine labs were normal, and the MRI showed moderate diffuse cerebral atrophy. So the diagnosis is, if you work through it, you start with, does the person have chronic cognition problem? Chronic, 4 years. Cognition, yes, it's affecting her short-term memory. She's having visual, spatial, and executive functions with driving in the wrong direction. And then she's lost function. She's not handling her finances as well. You've ruled out other conditions like depression. Physical exam is not showing any signs of stroke or Parkinson's disease. She has trouble on a pen and paper screening test. You're pretty much looking at dementia, and then the story of the slow progression over time fits with AD, so AD as your diagnosis. And then these are just other examples that I'll pass my way through. And as we go to the last section, I just wanted to give a sense, well, what do we do after we make the diagnosis of what is happening? Well, I always think about the target or the broader circle of what we do in comprehensiveness. And so The first thing is we have to help the person with the, individual experiencing cognitive loss to make sure they feel the center of it, they maintain their abilities and capabilities, and they can do things to try to help maintain their quality of life as best as possible, and to make decisions about options for treatments. Then you have the caregivers that have to be part of the support team, followed by the primary care health services and their engagement and coordination of care there, followed by ancillary services and community settings or other specialists that are being engaged, and then the social, legal, and community services. And it's building this entire web that you work with people over time, and you don't have to do all of it at once. But what I usually tend to ask in my first visit is I focus on making the diagnosis. I remind people that they might not remember much after I make the diagnosis, and that I'm going to write that in my AVS or my note that they will get afterwards so they can read, and then they can ask questions afterwards. But I do try to ask, well, what is the biggest issue you're experiencing now? And try to find if I can work through that with them so that they can get some immediate relief to their burning question. And then we work on building the other layers over time. And really the layering of it is like the constant education, the learning of, how to connect and network with social services. And then medications are part of that experience. And really what we're trying to do is maintain people's cognition for as long as we can to reduce some of the behavioral changes associated with Alzheimer's disease, because those are the things that eventually burn out the caregiver and can cause somebody to need more professional care and institutional care. But we want to maintain their function for as much as possible in doing their day-to-day activities and focusing on their abilities rather than their disabilities over time. Well, mild cognitive impairment has gone through some changes over the last year, but really it's to educate people that it's an increase in the pathway to progress into dementia, and that there's needs is a good time for people to start building that network and their team. The first drug in 2022 that got approved with an FDA indication for removing amyloid was aducanumab. That drug is no longer in the market after some of the controversies associated with it. But now in 2023 and 2024, we have lecanemab and donanemab, which are these amyloid agents to remove amyloid with an antibody capabilities through infusions. And they're approved for the treatment and moderate modification of the disease at an early stage in mild cognitive impairment and mild dementia. When people get to a diagnosis of dementia, it's helping them to start setting up plans and understanding what the processes are with the caregivers and to be part of the active role in deciding their network of care. There's things we can do to make the journey better and more improved quality of life, and that healthy choices that they maintain are important, not just for maybe the Alzheimer's part, but the vascular and the stroke and the other conditions that if we can prevent, we can help maintain people's functionality for longer. There's many social service options and finding resources through the Alzheimer's site by the National Institute on Aging or the Alzheimer's Association. And we kind of don't always recognize, or we should learn to have this information about sort of our local area agency on aging or senior services center that can help people in connecting to some of the services. And we may at some point have to use things like driver's evaluation programs or getting people a bracelet for a safe return program or caregiver support groups over time. And then there are medications available. And if you want a nice summary of the medication, there was a 2024 article in the American Journal of Family Physicians about the most common treatments and cognitive functions and going over some of the risks and benefits of the new medications. We know multiple medications in clinical trials over 30 years have not been supportive of helping people that already have dementia. And then to help with the behavior and mood changes, we tend to use antidepressants if we think anxiety and depression is present. And then antipsychotics are really of limited usefulness. There was one that was just approved for agitation in AD called brexpiprazole that needs to be considered. And then if we go in the final stage, I did want to talk about what's coming next. And this was some exciting work and to try to make this follow-up after a diagnosis is made clinically a little bit easier to confirm and to get people ready for some of the new agents in the early stage. And that's the idea of moving away from cerebral spinal fluid and from PET imaging of the brain to detect amyloid and tangle pathology with p-tau into using a blood-based biomarker. And these two papers did make a difference and were published in JAMA in the same issue, Journal of the American Medical Association. One was looking at a blood-based marker, they tested it in Scandinavia, in Sweden, in a primary care center, which I give them a lot of credit for because most of the times they just focus on specialty clinics. And it does have some properties, especially the phosphorylated tau percentage of 217, and then the score of amyloid beta 42 over amyloid beta 40 could be beneficial in confirming that the diagnosis of Alzheimer's disease and helping after the clinical work has been done. People also looked if you could test people separately in midlife and follow the trajectories of these biomarkers. And they did show some prediction capabilities, but still not to be used by itself in midlife because they aren't accurate enough as standalone tests, including the APS2 and the p-tau. We still have to make the diagnosis as primary care physicians in the mild phase, and then think about the evaluation that's needed for people to be considered for some of the new agents and to make a shared decision about them. So we have a lot to still do together in understanding what is causing and driving some of these things with cognitive decline, especially the 40% we can't always explain with our current pathologies. What are these risk factors that can be modified? The study that was done with the biomarkers in the ERIC study pointed to an interaction with conditions in midlife like high blood pressure and cholesterol and diabetes. The bread and butter of good family physician primary care in midlife. So if we can keep working on those activities, maybe we will improve and reduce or delay the incidence people 40 years later. And then how do we keep looking for these biomarkers, especially these blood-based markers, to help us in the prediction, the diagnosis, and the treatment phases, and understand what are these accelerators and how do we reduce health disparities. So research is part of that, and we have to continue to work as groups of primary care providers with communities and researchers and families to understand these pathways and provide some resources here. So with that in mind, cognitive disorders are going to be increasingly common. They already are. They're just going to get to be more. Family physicians are well qualified to be leading these efforts, and they're doing it now, and they should have the confidence and continue to build their confidence in doing it in the future, at least in the early stages of diagnosis. And we're getting to the point where some of our treatments will go through more iterations to get better options, but are to help with diagnosis and treatment. And we need to kind of keep encouraging research to advance and build on the work we've been doing in the past. So I finally left some resources here and my contact information if people wanted to contact me with anything further, but I will end there and open it up for any last minute questions. Thank you for paying attention, and I really appreciate the opportunity to share and hope we can learn together as we keep growing in these spaces. Thank you. Talk to you later.
Thank you so much. Thank you so much, Dr. Shah. We have quite a number of questions here in the chat. Continue to put your questions in there. There's about 6 right now, more coming, and 3 of them are fairly similar. So I'm going to truncate those for you and start with, can you discuss some of the significant risks of infusion treatments? Along with, please clarify if it is the standard of care to prescribe infusion therapy for all patients with MCI and beyond. And then also, has the approval of lecanemab and donanemab changed anything in your practice?
Yeah, no, great questions, and I appreciate them. So I think we're still learning in the early phases, even in specialty clinics, about how to best handle the decision-making around these 2 new disease-modifying treatments that have FDA approval. I don't think these are going to be things delivered in primary care because it takes significant amount of time to reach a shared decision. The treatments are not going to be for everybody based on what happened in the clinical trials. People should be offered the options, but they might not qualify because the qualification is based on checking for how much amyloid people have and how much potential tau they have, either by CSF fluid right now or with brain scans. Eventually, hopefully we can replace that with the PET scans or the CSF with blood markers. But for now, you need to have people have enough amyloid in their brain for them to even think about qualifying for an infusion pattern. One of them is like every 2 weeks, and the other one is every month. People have to be prepped to come in for that. They have to be prepped that they're going to get modest change in the trajectory of their cognition. But if we're doing it earlier, we're hoping that the studies have not been long enough to see like how that separation happens over time. Most of these studies were on the range of about 18 months to 3 years of follow-up. But there are risks, and about 30% of patients on amyloid agents and develop something called ARIA, which is this sort of inflammatory process or edema process in the brain. It can be reversed, but it is tricky because you're treating people early where they have some main function and capabilities, but they also could decline because of some of these side effects that can happen with changes in the brain. So in a primary care setting, I would say what's changed in practice a little bit with these new agents is we need to get better at that earlier diagnosis. It doesn't mean that everybody with MCI or that we diagnose early should go on to get treatment. What it means is they should be offered that opportunity by earlier diagnosis, and then by talking with them about, there are these agents available, they have potential benefit, but they have side effects too. Some of them, pretty important ones because they affect edema in the brain or some bleeding of some blood vessels. And you should talk about them. And we need to look and work with our neurology colleagues and others that are offering these treatments to make sure you qualify for them. And if you don't, you should, if you're interested, you want to learn, I can connect you with those places, but you're not required to have to do it. And if you don't qualify, it doesn't mean there's nothing we can't do. And I'll still be part of the process and follow you along the way. So it's definitely a lot of shared decision making to walk us through this first couple of years of these treatments, and realizing that for about 100 people that we diagnose with MCI, maybe about 2 to 10 will qualify for these medications, but we as family physicians have to take care of the other 90 and help them through the process by walking the journey with them.
Thanks, Dr. Shah. You've got a bunch more questions here. I'm going to start at the very top, with the first ones that came in. With a 92-year-old newly diagnosed with Alzheimer's disease, how aggressive do you get with I'm guessing it's medication and treatment?
Yeah, well, it's a great question. Again, part of the shared decision-making process that we have to deal with. And I wouldn't tie it by age alone, right? I think there's no marker for age. A 92-year-old woman, right now, average stats in the United States will live another 5 years. For a man, maybe another 3 years, right? So it becomes a question of, where are they in the process? It's not the age, but it's sort of like their frailty, their multiple morbidities, what they value. And I go back to sort of the geriatric 4 M's, like what's the most important thing that they value in their lives at this stage? What's the, what can we do with their medications to streamline or improve them? What do we help with their mentation? What do we help with their mobility? It has to be a discussion point. We shouldn't not take anything off the table, but we should at least have that discussion with people about what seems reasonable and not reasonable from their perspective. And what I found working with individuals that are in their 90s is that most of them will tell you what they want. It's usually their kids or their older adults that are their children or their grandchildren that don't quite understand how to come to terms with what the older person wants. So it does take a little bit of that family dynamics and just getting everybody on the same page and working with them to support them through it. So I hope that helped.
Thanks, Dr. Shah. I'm going to truncate 2 of the other questions that I see here. One person has asked, through Quest, we can check proteins for Alzheimer's disease. Do you recommend this beta amyloid 42/40 ratio? And then someone else asked, how reliable are the A beta amyloid 4240 and PTAU 217 tests.
Yeah, so I mean, I think the article does a very nice job in primary care and specialty setting in showing that these tests did improve sort of diagnostic capabilities for Alzheimer's disease pathology driving the amyloid changes when they compared it to like PET scans and CSF. So they do have value, and I'm glad that we're approaching that point. What I tried to show in that last slide when I showed those studies about the biomarkers is even the experts in the field based on those two studies are like really, like even the Palmquist one, which is the main one that dealt with the A beta 4240 and the p-tau 217. They ended up coming down to say they can't be used by themselves. So this is not the test in primary care to say when a person comes in and says, well, by the way, doc, I'm having troubles with your memory. Oh, no problem. Let me order this amyloid test for you, right? Like I would not recommend that. That's not where these treatments were developed and what knowledge we have about that. They may come over time, but it's not showing that that's how the use was in our knowledge base right now. So what has to happen is you still have to spend the time with that person to go through those 3 steps, make the diagnosis. Do you really think it's MCI? Do you think there's anything else going on that you're worried about as far as what is happening? And if you made the diagnosis of MCI or early dementia, then you can probably use this test to help you to understand if there's enough amyloid and enough potential tau pathology that could drive us to then, seeking out that specialist to look at the discussion about some of these new agents like lecanemab and donanemab. So I think we're optimistic, but we're very cautious about it, and definitely not based on the study that was done in the middle age group. Should we be using these biomarkers as their self to predict what happens? Now with ApoE or E4, because I think that was one of the other questions. I think if we're going to go down the line, somebody of working through the shared decision making about should somebody be taking one of these new agents that are infusions, we need to know their ApoE status, because both of the agents have shown clearly that in people that have 2 copies of ApoE4, their risk of bleeding is increased, right? Those area events are increased. So there has to be a more in-depth discussion happening with the specialist about whether the treatment is an option or not. And a lot of the specialty teams are really not advising it, for people until we get more experience if they have the ApoE E4 dual allele. And that if you have one, that's a discussion, but you're still a little bit increased risk, but we have to, not as much as if you have both. So yeah, some of these things are changing as a result of these new options, but the first thing is, do people want to even consider going down that pathway? If they don't want to consider it, we don't worry about those things. If they are considering it, we may have to look at the ApoE, we may have to look at some of these markers, or we're going to have to get a PET image or something to tell us they have amyloid in their brain, so they qualify to be part of these studies, or part of these treatment options.
Thanks, Dr. Shah. Okay, it looks like there's just 3 questions left, and I'm going to piggyback with your answer from the last one. We have one question that says, is the amyloid a cause of or a consequence of Alzheimer's disease?
Yeah, that's a great question. I think we're realizing that amyloid is a key player and its presence, and that's why we define it in the pathology. It is not the only marker, and it's not always clear like what part of the amyloid pathway is the driver. So it may not be the plaque that we see. That might be the response of a body trying to adapt to what is happening to the other smaller parts of the abnormal A beta protein that eventually polymerizes and becomes the amyloid, and the polymerization with inflammation creates the amyloid plaque. So I think people are more aware and are more accepting than even 20 years ago that amyloid is one part of the pathway, but not the only pathway. So we do need other treatments through research that target other ways of approaching things. We have just made a little bit of success in the amyloid hypothesis and showing that if we remove it, that, there are some changes in cognition. The studies like the ERIC studies and prior studies have shown that amyloid buildup and then is associated later on with other changes in the brain, including neurodegeneration. So there seems to be a amyloid cascade and temporality to it, but it's not so clear and it's not the only answer.
Thank you. We have one question on screening, the MMSE versus MoCA versus MiniCog. Any preference, or do you think one is better than the other?
Yeah, the best data from the U.S. Preventive Services Task Force, when they evaluated this a few years ago in an update about, how do we screen people asymptomatically? They looked at the screening tools. They all perform around the same, for this 5-minute brief screening. And I think that's the key. It's a screening tool, right? Like it is not by itself the tool that's going to get you the diagnosis and all the information. It's just going to give you a clue that somebody's on a pathway that might not be showing, that they might be showing difficulties with their cognition. There's no clear answer, from a testing point of view, if one is better than the other. So whatever you're most comfortable with and trained and have accessibility to, the better off. It's just to use something, right? Like I think that's the main thing. To document that there is some change that's noticed is very helpful to have in the chart. They all have their other issues around required training and licensing rights. So you just have to kind of find, and I would add slums as another tool in that space that people could use and has some properties. So yeah, it's whatever you prefer and have confidence in using.
Thank you. And here's our last question. Is there enough data to tell people to avoid aluminum and plastics in food and in drink containers and in cooking materials to avoid dementia?
Yeah, that's a great question. I'm not sure I can talk as much about the plastic side. I'd have to look up that information a little bit more. But I do want to give the story a little bit about the aluminum side, because that's been present since the 1970s. So what drove people to think about aluminum was in the original kidney machines that were developed for renal dialysis, they used an aluminum component to remove some of the toxins from the urine stream before blood was entered back. And some of that aluminum leached out from the machines and back into the bloodstream. And people that did have, had no kidney function. So then that aluminum collected in people's organs, including their brain. And that's why the aluminum story came in, because it was associated then with neurotoxicity and dementia. People that have routine, normal clinic, like kidney functions, not on dialysis, this has not been seen as much of an issue that you have to avoid it because your kidneys will remove it. There is a lot of work going on in these other pathways to look at the exposures to metals and now even microplastics and multiple organs to see about their impacts over time. And we're still learning about what those processes are and what role they play. So there'll be more to come in this story, but just a little bit of the update on the history around the aluminum story and the fact that if you probably have normal kidney functions, you're okay with, using aluminum cans for your sparkling water or something like that.
Thank you so much. And I think that concludes our presentation. Thank you so much, Dr. Shah, for this very informative update on the Brain Trust. And just want to remind everyone, the link to claim your CME credit will be emailed to you after the presentation. And for those of you participating online and during, a link to the post-test eval and credit claim can be found in the video description. Please click on the More tab to get the full link and the video description.
Thanks for all the great questions. Really appreciate it.
Thanks so much. Until next time.